So welcome everyone. My name is Joshua Rosenblat. I'm in Toronto, Canada, and I'm joined by Danica Johnson, who's also at the University of Toronto with me in Canada. Welcome to everyone that's tuning in globally from wherever location you are, and we're very excited to share with you today a presentation on psilocybin and depression, specifically focusing on insights from contemporary clinical trials. So we're going to dive right in because we have a fairly jam-packed hour for you that both Danica and I will be presenting on a number of different topics. The objectives are fairly straightforward. We want to critically evaluate the current clinical trial evidence on psilocybin as a treatment for depression. We're going to be looking a lot at the efficacy, but also the safety and methodological strengths and limitations. We want to discuss regulatory, ethical, and operational steps. And as we have background for this session, as the psychedelic GNC, we're really interested in supporting people globally who are interested in getting into psychedelic research. And we know that there's lots of people that are interested, and we're hoping that this session can provide a bit of an introduction not only to the data and the efficacy, but also a bit of lived experience that Danica and I have from running these clinical trials to share a bit about the hurdles and challenges and successes of getting these studies off the ground. We do want to talk about some of the emerging issues, debates, and unresolved questions. Certainly, there are so many debates going on in psychedelic science right now, so we'll only be able to touch on a few of them. And to highlight that this session is specifically focused on clinical trials, whereas we're hoping to have subsequent sessions also on preclinical work and more mechanistically focused work. We'll talk a bit about mechanisms today, but primarily we're going to be focusing in on clinical trial evidence, as this is our main area of expertise for Danica and myself. Before we dive into the topic of psilocybin for depression, I wanted to, of course, highlight that we're dealing with a major challenge globally right now where depression outcomes remain poor. I've prescribed SSRIs, antipsychotics, and a variety of medications, as well as provided cognitive behavioral therapy to thousands of patients. And I find them to be incredibly beneficial for so many people. And at the same time, unfortunately, we know from the STAR-D data and some similar studies that treatment-resistant depression is very common. And once people have failed two or three conventional treatments, it's very unlikely that they're going to respond to yet another conventional treatment. So looking to newer things such as psychedelics, ketamine, esketamine, these mechanistically dissimilar alternatives are really important. So we're not researching in psychedelics just because it's a hot topic and everyone's excited about it, but we're researching psychedelics for depression because we know current interventions are insufficient and inadequate, and we need to unapologetically insist that we do better for our patients with depression. So the first key point here is that treatment-resistant depression is common with diminishing returns of subsequent medication trials. So we need innovative treatments to improve patient outcomes, and that's where we are interested in psychedelics. So psilocybin is the active ingredient in magic mushrooms, and there has been tremendous interest over these past 2 decades, and even beyond then with the first bout of research in the 50s and 60s. But certainly right now, this has been front and center globally as a very key intervention for us to evaluate. So psilocybin is a naturally occurring psychedelic found in magic mushrooms. It's metabolized to psilocin that acts as a serotonin 5-HT2A receptor partial agonist that occasions the non-ordinary state of consciousness. And there's been interest for applying this to many psychiatric conditions, but especially for major depressive disorder and treatment-resistant depression. When we talk about PAP, psilocybin-assisted psychotherapy, this is specifically talking about combining psilocybin with psychotherapy, which would typically include preparation sessions leading up to the dosing session, a supportive dosing session, and integration sessions. Danica is going to expand on this a bit further as well in terms of what this actually looks like within our clinical trials. We hypothesize that psilocybin may act as a catalyst to achieve greater benefits from psychotherapy that may not have been possible without psychotherapy alone. But this too is a testable hypothesis. One of the major questions for the field right now is psilocybin effective as an antidepressant on its own, or do you need it to be combined with psychotherapy or psychological for it to be mid-build. Right now, for many of us, we're believing that the combination seems to be quite important, but we have some trials upcoming as well, which will further test the precise nature of the psychological support that would be needed to optimize safety and efficacy. I wanted to share a picture of one of our dosing rooms. We have three dosing rooms at University Health Network here in Toronto. This is the one that we primarily use at Toronto Western Hospital, the building that I'm standing in right now. This is just a few floors above above where I am now. And as you can see, it's a very comfortable, beautiful living room-like setting, and it looks quite different from a usual hospital room. So right from the outset, when we start to think about things like expectancy and placebo, we need to start thinking about these factors where people are coming in and we immediately are trying to provide this sense or feeling that this is a place of healing, not just a place of sickness, and this is a place where you can be comfortable and explore things in a natural way. So quite different from the current model of what a hospital room would look like, what an interaction with a psychiatrist would look like. So an important thing to recognize right at the outset that this is quite different from what it would look like when you're going to see your family doctor or other care providers to do cognitive behavioral therapy or to start an antidepressant medication. Now, the focus of today's talk is on depression and treatment-resistant depression, but I'd be remiss not to comment that psilocybin is being studied for so many indications, both psychiatric and physical, things like depression, anxiety, PTSD, bipolar disorder, Lyme's disease, chronic pain, all these different things psilocybin is being studied for. And Danica and I had put forward this idea in Nature Mental Health a couple years back, this idea that maybe psilocybin is not just an antidepressant, but an antidistressant, which, yes, is a new word that we came up with. That's not a real word per se, but hopefully it'll catch on. And this idea is that what unites all these conditions, all these psychiatric and physical conditions, is significant distress. And it seems like in our experience that psilocybin transdiagnostically reduces distress levels, regardless of what the primary diagnosis is. So we'll be focusing on depression data, looking at outcomes like the MADRS and the HAM-D, but important to highlight that psilocybin is being explored for many indications, and we may find out at the end of the day that this is not just an antidepressant, but something much more. For those that are interested in having a summary document that goes over the basics and beyond of psychedelics, classic psychedelics, including psilocybin, we put out this national consensus statement in Canada with the CanMet group, where we go through the basics basically. So we have these Q&A. This is available open access online, so anyone can freely download it. But we just have these basics of what's the mechanism of action, what's the pharmacokinetics, does it have efficacy, what's the safety, what are the medical legal considerations. So I do encourage you to have a peek at that if you're hoping to have a bit of a primer on this topic. So as I mentioned, we're focusing on clinical trial data, but wanted to briefly summarize some of the mechanistic data. So the primary target that's been of great interest has been the serotonin 2A receptor. As I mentioned, psilocin, the active metabolite of psilocybin, acts as a partial agonist of this receptor. And what we do know about 5-HT2A is that it is responsible for the psychedelic or non-ordinary state of consciousness. What we don't know is that receptor and the psychedelic experience essential for the antidepressant efficacy. And that's a testable hypothesis that our group and others are working on right now as well, as a very provocative and interesting thing where we've thought that these things, two things go together, that the psychedelic experience and the downstream effects of serotonin 2A receptor are what causes both the psychedelic experience and the antidepressant effects, but something we need to explore further. The biopsychosocial spiritual downstream effects of the acute mind revealing experience. This idea of mind revealing also ties to the definition of psychedelic, which, when you break it down to the Greek of psyche and dolos, that roughly translates to mind revealing. So these are not just mind altering substances where you feel a bit loopy and a bit off, like you would with alcohol or other mind altering substances, but this idea that there's more to this, that it could actually reveal something and help you to provide insights where you're having this biopsychosocial spiritual effect through the psilocybin in combination with the psychological support. Lots of interest in neuroplasticity and the direct effects that this has on BDNF and the receptors of BDNF. This idea of increased amygdala reactivity, changes in default mode network. There was that amazing mega analysis published in Nature Medicine earlier this week that was fascinating as well, looking at the circuits and the changes in brain activity in relation to psychedelics. Lots of interest in anti-inflammatory and antioxidant effects. My personal background is previously studying anti-inflammatory and antioxidant interventions and seeing that this could be beneficial for a variety of disorders transdiagnostically. So interesting to see this come in full circle, where for psilocybin as well, there seems to be quite potent anti-inflammatory and antioxidant effects. And then placebo, is this just a nuisance in clinical trials, or are we actually leveraging the neurobiological effects of a potent placebo and expectancy response that's causing real brain changes through this mechanism of well-documented neurobiological effects of placebo? So many interesting mechanisms. But I want to highlight that these are all testable hypotheses where we're not sure exactly, with 5-HT2A being the perfect example, where there's been so much work right now around non-hallucinogenic psychedelics or 5-HT2A independent effects or biased agonist effects that reduce the psychedelic experience. We had a case report we published a couple of years back, which, to my knowledge, was the first human evidence to support this idea, where one of our clinical trial participants had inadvertently taken trazodone that has potent 5-HT2A antagonist effects. This participant had had dozens of medications, tried TMS, ketamine, all these different things, and was severely unwell for 8 years. And after having a single dose of psilocybin, where the psychedelic experience was oh, I think some people just need to mute themselves. Thank you. Where there was no psychedelic experience, presumably because trazodone was blocking the 5-HT2A receptor. And we're scaling these people extensively and finding no psychedelic experiences at all in this individual. And despite that, he had a dramatic antidepressant effect that lasted 6 months out to the end of the observational period of this study. And there's been a lot of interesting animal work as well in this area. My colleague Ishrat Hussain is leading this study that is hoping to read out very soon, where we combine psilocybin with risperidone, which is also a very potent 5-HT2A antagonist, where we were trying to test this hypothesis further, where one, could we effectively block the psychedelic experience? And two, for the people that had a blocked psychedelic experience that still received a full dose of psilocybin, did they have antidepressant effects? So this is a pilot study, but very provocative, this idea of maybe it's not 5-HT2A, and maybe we don't need the psychedelic experience for people to have the benefits. So all this to say that the mechanisms are still a vastly questioned area where we can assume nothing. We have these hypotheses about what are the main mechanisms of action, but we still need to rigorously test this. So there's infinite experiments that we still need to do to fully understand how is psilocybin actually exerting its antidepressant or antidistressant effects. Fascinating study. I mentioned, we're not going too much into the preclinical, but I thought this was an important one to mention, where this study published in Nature Neuroscience found a fascinating effect where psilocin directly binds to TRK beta, the BDNF receptor, with affinities 1,000-fold higher than those of other antidepressants. So this is not relying on the serotonin 2A receptor. This is direct binding of psilocin to the TrkB receptor. So very fascinating, where we know that neuroplasticity is a common pathway for antidepressant efficacy, but for some people, they're not having neuroplasticity induced through antidepressants. So it may be that psychedelics, and psilocin in specific, has potent effects on improving neuroplasticity. And this is where the term psychoplastogen comes from, where we're starting to refer to sometimes psychedelics, not just as psychedelics, denoting them based on their categorical mind-altering experiences or mind-revealing experiences, but more so denoting them based on the common pathway of tremendous increases in neuroplasticity. This I find fascinating, this idea that increased amygdala reactivity with psilocybin was predictive of antidepressant efficacy in this initial pilot study by Rosenblat and colleagues out of Imperial College, where the idea here is that in treatment-resistant depression, we're giving people antidepressants, which we know turns down the volume of the amygdala. The amygdala, the emotion center of the brain, we know that for many people with depression, the amygdala is hyperactive and they have an increased emotional response to negative emotional stimuli. And so we need to turn down their volume so that they are not having such intense negative emotions in relation to negative emotional stimuli. So we know that's how SSRIs and antipsychotics work in the depressed brain. But for people that are not responding to that approach, maybe we need to actually turn up the volume, allow them to feel their emotions and experience their emotions and process them in the psychotherapy or psychological support. And that could lead to the ultimate healing. And that's what they found here, where a strong predictor of antidepressant efficacy was increased amygdala reactivity to negative emotional stimuli specifically. So fascinating that these patients that were able to feel their negative emotions more strongly were able to have a greater antidepressant effect with psilocybin. So in a very interesting line of research. And we are currently almost finished a clinical trial where we're doing this exact same experiment in bipolar 2 depression, treatment-resistant depression as part of bipolar 2 disorder, where bipolar disorder is thought of even more the prototype of the overactive amygdala, where we're testing this idea for people with treatment-resistant bipolar depression. Maybe they don't need us to turn down the volume, but actually turn it up because they're struggling with alexithymia and anhedonia and lack of ability to feel their emotions, in addition to the emotional blunting that may be caused iatrogenic from our medication. So a fascinating area there for sure. I could go on all day about the mechanisms, but do want to move on to focus on a few of the key trials to evaluate antidepressant efficacy and safety of psilocybin. So we won't have time to go over all the trials because there are many now, but did want to briefly touch base on some of the key ones. So this was the first study in treatment-resistant depression, which was a small open-label feasibility study led by Robin Card Harris and David Nutt out of Imperial College. And in this study published in Lancet Psychiatry, 12 people, which, this is just fascinating in itself in terms of that this study was published in Lancet Psychiatry despite being a 12-person open label study, but just highlighting the importance of this to the field, where they saw dramatic reductions in the BDI scores and quite rapid and robust antidepressant effects in many of these individuals. For those that are interested, I highly recommend this documentary, Psychedelic Medical Trial, The Healing Mushrooms, which really documents this clinical trial. It's available for free on YouTube and is very interesting to see how the trial was conducted and also all the non-pharmacological things around it in terms of the setting and the involvement of Robin and others, and just how all that could impact the effect, especially within the context of an open label study. So very fascinating to see this first step and this very exciting step towards a breakthrough treatment for treatment-resistant depression in this initial open label study. Our largest published evidence available right now by Guy Goodwin and his team at Compass Pathways, published in the New England Journal of Medicine back in 2022, was a really rigorous, well done, large phase 2 study with 233 individuals randomized to 25 milligrams, 10 milligrams, and 1 milligram. And what they found was they were able to demonstrate safety, tolerability, and efficacy for the 25 milligram group, which was received by 79 individuals. So we're seeing on their primary outcome change in the MADRS 12-point drop, which is massive in treatment-resistant depression compared to a 5.4 drop, 5.4 point drop in the 1 milligram group. And the 1 milligram group, remember, is also receiving significant psychological support. So it's not like they're receiving nothing. So this isn't just a pure placebo or a waitlist arm like we're going to go over in another study. So we're seeing, quite nice differences. And this is also the study that has pushed us all to use the 25 milligram dosage. We don't know, maybe a higher dose is even better. And that's a question that we have in our lab in terms of maybe people need 30 milligrams or 35 milligrams. Maybe we haven't reached that ceiling yet. But what we do know is that the 25 milligrams has a very good signal for efficacy, and seem to be very well tolerated as well. On the dosing day, everyone experiences adverse events. That's expected. Perhaps the one of concern was there seemed to be, a bit of a signal around suicidal ideation or behavioral self-injury, where these are very small numbers. So it's really hard to know, is this clinically meaningful? But 3 people in the 25 milligram group, 2 people in the 10 milligram group, and one person in the 1 milligram group after week 3 out to week 12. And then similarly, you're seeing a similar effect in the day 2 to week 3, that sort of ultra acute effect. And this intuitively makes sense to me because psilocybin is such a potent molecule. And for people with severe malignant treatment resistant depression, there can be suicidal thoughts that come up. It's almost like you're shaking up the snow globe, and there can be unexpected things coming up. And this is why, I'm of the belief that the psychological support and close monitoring is so important. So this is very different from, for example, someone taking psilocybin on their own in their basement or with a friend where there isn't that monitoring and support. But within our clinical trials, even if this signal is true and there is a dose effect, I think that this risk is very easy to mitigate from the perspective of giving support, helping people work through, having someone express their suicidal thoughts and working through that with them together can be therapeutic in itself. So, this signal is, I think concerning from a regulator perspective and all these things. And at the same time, to me, it's not that surprising, given how potent these molecules are and how sick patients are that are often enrolling in these studies. What was very exciting as well is this is just one dose of psilocybin, and we're seeing these effects lasting out to week 12. So very exciting to see such a rapid, robust, and enduring effect, where some studies have found that with 1 or 2 doses, you're having effects last for several months later. So that's completely different from, for example, having a single dose of an SSRI, or even when you compare it to something like ketamine, which is another big area of interest for us. We would never expect a single infusion of ketamine or a single dose of S-ketamine would have lasting benefits 12 weeks out. So very different from everything else that we really have in terms of interventions right now. So it's exciting nonetheless. I wanted to be careful at this global webinar to not go too much into detail of unpublished results, but certainly important to mention the recent press releases with the second phase 3 trial evaluating Compass 360 psilocybin. So that's the 25 milligram dose for treatment-resistant depression. So it does seem like, based on the press release, that both phase 3 trials were positive, meeting their primary endpoint, where we do see a clinically meaningful and a statistically significant antidepressant effect in both these trials. And of course, we await and are excited to see the published results for this. Also wanted to mention a very recent study just published a couple weeks back. We were very excited to see the study, the episode trial coming out of Germany. Very well done, academically funded study with 144 individuals. So this is the largest academic study completed to date with psilocybin, and they had very interesting four arms in this. And their primary they chose to be antidepressant response based on a 50% reduction in the HAM-D, and this was negative without a between group difference. However, the more conventional endpoint would be mean change on either the HAM-D or the MADRS. And in terms of mean change, when you look at the between group difference between the 12.5 milligram dose and nicotinamide, that was statistically significant and clinically meaningful at 4.6 points. Officially a negative study, but positive in some ways as well. And this study also highlighted that the safety and tolerability was good, with one case of HPPD. And to my knowledge, this is the first case of HPPD being published in a contemporary clinical trial. I think it's a rare adverse effect, but something that we're going to be seeing perhaps more of as we have more trials. It's also being studied for major depressive disorder. So this is not just resistant depression. So Compass Pathways is developing it for the MDD indication. And we see this study led by Chuck Grayson, Jerry Sanacor, Josh Willie, and colleagues published in JAMA. Where we're seeing a tremendous effect, so almost a 20-point drop on the MADRS, so a 12.3 between group difference. So it's seeming like in the MDD group this is highly efficacious and well tolerated also. Of course, this sort of leads to the question of, is psilocybin more effective than standard of care or SSRIs? And in this nice study done by Robin Card-Harris and colleagues published in the New England Journal of Medicine, for their primary outcome, which is the QIDS, which is a bit of an atypical primary outcome. We're usually using the MADRS and the HAM-D, but for a number of reasons, they selected the QIDS for this study. They found that they did not reach statistical significance. The sample size is modest. This likely was underpowered at 59 people. There still was a 2-point difference favoring psilocybin. But what was fascinating was all the secondary outcomes. So the QIDS, the primary outcome, was the only one that was negative. All the other ones, including the FDA ones, the HAM-D and the MADRS, were strongly positive. So it seemed like on every other measure, psilocybin beat out escitalopram. And importantly, when they looked at secondary analyses, they found that the effect probably was being driven by people that were still in a bit of serotonin discontinuation syndrome that was being treated by the SSRI. And when they only looked at people that were unmedicated at screening, in that group, psilocybin was way better than the SSRI group. So very fascinating to see all these confounds in this. So to finish up, I just wanted to give a bit of a case study for our first investigator-initiated clinical trial. So this is Canada's first investigator-initiated trial, where we published this a couple years back in Med by Salt Press. And it really was brought on because we were trying to get access to psilocybin for our patients, and Health Canada advises that the best way to do that would be to conduct a clinical trial. So this trial was a trial initially for access, but we were able to do some good science as well. We did a waitlist control because we wanted to allow all the participants to access the treatment, since that was one of our primary goals, just to provide access to patients in Canada that were trying to access psilocybin. And we had a number of unique things here. We had a very brief psychological support paradigm where it was just one prep session and two integration sessions. We allowed for flexible repeated doses. So if someone responded and then relapsed, they could get a second or even a third dose over the course of 6 months. So a number of unique elements here, but perhaps the most unique element was how broad our eligibility criteria. So this is still the only published RCT to include bipolar disorder. We included bipolar 2. We had no upper limit for degrees of treatment resistance. People had ECT, ketamine, all these things. And so we were very flexible trying to make this a real world study. We had the preparation session. This was done not at University Health Network. This was done at Canadian Rapid Treatment Center of Excellence, which is in a small strip mall, essentially, in a suburb of Toronto. So it's not the ivory tower that's typical for a lot of the academic studies here, and a fairly humble dosing room, very different from the picture that I showed you earlier about our current dosing room. So we had the dose, the monitor dosing sessions, and then integration as well. This was also started and finished during the pandemic. We had to grapple with using masks and all these things, and we didn't exclude complex patients, even people with severe comorbid borderline personality, PTSD, and suicidality. So our primary outcome was that baseline to 2 weeks, and we did find a rapid and robust antidepressant effect compared to the waitlist control arm. We also found in the bipolar subgroup that they responded very well. Also, just four people, so we can't draw any conclusions from this, but encouraging also that none of them went manic or hypomanic. But most encouraging, I think, was this paradigm that we were using, where we used repeated doses over the course of 6 months, worked very well. Where you can see this line basically staying low, where as people started to show symptoms, we repeated the dose, and that worked very well. Where the antidepressant effect size was even greater with the second and third dose. That seems like that might be a paradigm when we move this into clinical practice, where patients might need some degree of repeat doses over time, particularly for people that have chronic treatment-resistant depression. So certainly lots of limitations, small sample size, but this does provide this preliminary support for use of psilocybin in a more complex real-world setting. The brief therapy protocol seemed to still work quite well. Repeated doses were associated with greater antidepressant effects, and we were able to leverage this pilot data to acquire funding from several grants federally, provincially, and locally. And this is something too that we hope globally to help other people as part of CINP do in terms of conduct these initial pilot studies, not just to do a pilot study in itself, but then to grow your clinical trial programs to do more psychedelic research. So those were the individual studies that I wanted to highlight, but just larger scale, looking at the meta-analysis that we conducted, we are seeing this consistently large effect size of around zero point 0.8. For antidepressants, we're looking at 0.3. So very encouraging that seeing across MDD, TRD, and depressive symptoms in life-threatening cancer that there's these consistently large effect sizes being observed. Hundreds of people have gone through these trials now, and it seems like one or two doses last for 3 to 12 months. Safety and tolerability profiles are looking very good. Dropout rates are low. Questions about treatment emergent suicidality that I mentioned earlier. But I'm going to leave it there and turn it over to Danica. So Danica Johnson is an extremely talented PhD student that we have here at the University of Toronto that's really been leading the charge on psychedelic research and has been leading one of our large psilocybin clinical trials. So I'll stop sharing and I'll turn it over to Danica, who has a fascinating presentation focusing more so around the methods. Thanks so much for your attention, and we're going to take questions at the end after Danica's as well. Thank you.
Josh, you can see it okay, right? Or somebody? Yeah,
Yes,
I see.
perfect. Yeah, perfect. Thanks, Danica.
Yep. Hi everyone. My name is Danica, as Josh mentioned. So the second part of this talk, I'm going to focus more on the design choices of how we go about making these trials with psilocybin, rather than the promising results that Josh happened to share with you. So my focus today, again, it will be on intervention design, comparator challenges, outcome measurement, and also the unresolved questions that will kind of shape where the field goes next. So beginning with the intervention itself, in psychedelic assisted psychotherapy, or PAP, I'll refer to it as, the intervention doesn't just seem to be the drug. So it's kind of this complex package that includes dosing decisions, the surrounding psychotherapeutic container, also the physical and relational environment, which Josh kind of touched on, and even what happens after the trial ends. So designing this intervention is much more multi-dimensional than maybe your typical drug trial. So starting with our dosing strategy, this is continuously evolving. If we look historically, dosing was typically scaled to body weight in a range of zero point 0.2 to zero point 0.4 milligrams per kilogram. But now most contemporary trials have shifted to a fixed 25 milligram dose, as Josh discussed through the dose finding study that Goodwin and Al did. And this is seemingly empirically supported, so the shift from the weight-based to a fixed-based dose. So we have pharmacokinetic data that shows us that a 25 milligram dose is comparable to around a zero point 0.3 milligram per kilogram dose. And we also have other studies that have failed to demonstrate a meaningful relationship between body weight, or BMI, and the intensity and qualitative aspect of the psychedelic experience. The more complex question that Josh touched on a little bit as well is the number of dosing sessions. So most of those studies he presented were a single high dose paradigm, and that has shown consistent evidence for rapid antidepressant effects. It's also much more simple to implement, lower cost, reduced participant and therapist burden as well. But does this maximize benefits? So there is some preliminary data, including the open label study that Josh showed from our group, as well as a recent Compass News report that suggested that additional sessions may produce cumulative reductions in depressive symptoms. However, the episode trial also on its own suggested that maybe adding a second dose doesn't have a clear advantage over a single dose. So there does seem to be this gap in our knowledge, and that's kind of the focus of what we're doing in our lab right now. Is we currently have a phase 2 RCT that directly compares one versus two doses, and that's kind of been the main focus of my PhD to get to the bottom of this question, hopefully. In terms of the psychotherapy protocol, there is relatively good convergence around the broad structure of psychedelic therapy. So, most modern protocols are following the triphasic model, which was originally introduced back in the 1950s and 60s. But essentially, this starts with a preparation and then leads to dosing and then goes into integration, which can be continued for many weeks. But what is far less settled is the actual psychotherapeutic content within that structure. So trials have incorporated many evidence-based approaches. So you'll see CBT, ACT, mindfulness-based as well. And then others have also looked at more non-directive support conditions. But currently, there is still no strong evidence that one modality is superior. So even though we talk mainly about psychedelic assisted therapy as if it's this standardized, manualized practice, it actually is highly heterogeneous, and many manuals remain unpublished for the trials that are currently available. The same heterogeneity is true for therapist training. So most protocols are requiring trained clinicians with at least a master's level of education, but there is no universally accepted competence or training model. And reporting of the therapist training is also inconsistent, the same with the manuals for the therapy itself. There's also ongoing debate around whether there are unique skills that one needs to possess to do this work, or even if therapists should have to have personal psychedelic experience to be administering the psychotherapy component of this. However, at present, there is no evidence that having personal psychedelic experience improves patient outcomes. And as you can imagine, requiring it may introduce bias and also limit the scalability of this treatment if we're excluding otherwise qualified clinicians who just don't have their own personal experience. All of this heterogeneity and uncertainty brings us to what maybe is the biggest question in the field right now, which is what is actually driving the therapeutic effect. One perspective put forth by Goodwin and others is that the drug itself is the primary active ingredient, and the psychotherapy is mainly the safety container surrounding it. However, there is some meaningful counter evidence to this in suggesting that the therapeutic context does matter. So, stronger therapeutic alliance, for example, has been linked to better outcomes, and higher support conditions as well appear to enhance both the subjective experience and clinical response. So, at this point, we don't have a definitive answer about this. The psychotherapy may be the active mechanism, it may be an amplifier, or maybe it's just this necessary safety container. We don't yet know this, but it does have major implications for how we design trials, train our therapists, and ultimately scale these treatments. So, this is something that we need to focus on as we move the field forward. Set and setting is one of the most foundational concepts in psychedelic therapy. Set referring to the internal state the participant kind of brings in, like their mindset, their personality, emotional state. And the setting refers to the external environment, so both physical and relational in this case. Dr. Rosenblat showed the image of our physical space, which kind of looks more like a living room, a safe, non-clinical space, and that's kind of standardized across the board in trials. However, when it comes to standardization, although that is important, personalization is also something that is increasingly being recognized as important. So, allowing patients to bring in personal objects like photos of family members or maybe something that's culturally significant to them, these objects can actually help improve safety and engagement. So, considering that, even things like music may be potentially tailored to the patient or the goal of the therapy or the clinical indication that you're testing. Something else to consider is what happens after the trial ends. So, in many cases, participants are experiencing substantial improvement during the trial, but once the study ends, they lose access to the intervention. And so, for some, this is also followed by relapse. So, what do we do next? I want to use kind of an example from our own work to hopefully incite some ideas in all of you. But we recently implemented a group therapy model for participants who have completed our psychedelic trials, which essentially gives them the opportunity to continue the integration process alongside others who have had similar experiences. And we found that this has been both clinically meaningful and well received by our patients. So more broadly, it kind of points to this integrated ecosystem where eventually, I believe, the responsibility for this post-trial care will be on the researchers, the sponsors, the clinicians, and also the policymakers. And beyond just like the ethical duty of this, it's also a scientific opportunity. So these follow-up structures can allow us to better understand relapse trajectories over time, also the durability of response, and what patients actually need to sustain benefit over time. Now, the comparator challenge is probably one of the most difficult things about designing a psychedelic clinical trial because of the functional unblinding and expectancy. So, blinding is a fundamental assumption of randomized controlled trials, but in psychedelic research, you obviously have this unmistakable change in perception and cognition, which makes it very difficult to blind. So, upwards of 90% of participants are able to correctly guess whether they received psilocybin or placebo. And this actually extends beyond just the participants as well. So, we're seeing that therapists and raters are also unblinded, which adds another layer of bias. And so the big concern with unblinding is that it initiates a cascade of expectancy effects. So before treatment, we know that our participants are coming in with these elevated expectations. So they're coming in with the sessions, also a big media coverage, and the cultural narrative around the psychedelic as well. Like there's Netflix shows about it and YouTube videos and everything. So big expectations. And then once this session begins, the participants in the active arm typically feel the effects and can correctly infer their allocation, which reinforces that positive expectation and influences how they interpret and also report their experience and improvement to us. On the other hand, participants in the placebo condition can recognize the absence of effects. And so that can lead to disappointment, disengagement, withdrawal, and also nocebo effects. So critically, most trials have actually not assessed expectancy or blinding integrity. So we're kind of left in a position where expectancy may be part of the therapeutic mechanism, as Joss mentioned, but we're not measuring it or modeling it, and therefore we're not able to disentangle the pharmacological effects from the psychological and contextual ones. And so, given the challenges with functional and blinding, another major focus in the field has been the development of active placebos. And the goal here is to create a control condition that produces a noticeable effect that's enough to preserve blinding, but also doesn't introduce any therapeutic benefit. And this has proven very difficult. So, beginning with niacin, this is the oldest that we have tried to use, but this even failed back in the 1960s in the Good Friday experiments. And yet, we still use it today because we have very little alternatives. Um, Methylphenidate or other stimulants have also been used to mimic some of the physiological arousal, but again, its effects diverge so significantly from psychedelics that most participants can identify what they received. Low dose psychedelics is another option, and this is great in the sense that you can tell participants that yes, you're going to receive psilocybin, but two problems emerge, which is one, the subthreshold doses are often perceptible to patients to be lower than the high dose, and so they assume that they didn't receive the high dose. And then second to that, we also have data that shows that the subthreshold doses may not be pharmacologically inert. So we have effects on BDNF, neural activity, and also emotional processing. So this doesn't really make it a placebo because it may have its own therapeutic properties as well. And the same thing is true for dextromethorphan. This one is interesting as well because it mimics some perceptual features of psilocybin, but it's been approved by the FDA as an antidepressant with bupropion, so making it more of an active comparator than a placebo at this point. Now, because active placebos remain unsatisfactory, the field has increasingly started to rethink trial design itself. So, moving away from how do we preserve the perfect blind to how do we design trials that remain interpretable even when blinding is imperfect. And so, I've presented four alternative designs here. The first is the dose response parallel design. So, all participants receive the active psilocybin, but at different dose levels, so that this can help reduce some of that expectancy imbalance where everyone is told they're receiving the intervention. The risk here is that you attenuate between group differences and underestimate efficacy if all dose groups have some therapeutic response. The balanced placebo design and enrichment factorial design follow the same more rigorous approach. In the placebo design, you would independently manipulate what the participants are told and what they actually receive. So you tell them they're receiving placebo, but they actually receive the high dose, or vice versa. And this can allow us to directly separate expectancy effects from pharmacological effects. Instead of isolating expectancy, you could also do the enrichment design, which is where you would try to isolate whether the level of psychological support or some kind of environmental enrichment affects response. Finally, you have incomplete disclosure. And with this one, you would not necessarily tell participants what they're receiving. So you could say you're going to receive potentially a range of psychoactive substances rather than a specific drug. And this can help again with some of those expectations, but it raises important concerns about informed consent and transparency. The other thing with a lot of these designs is powering them becomes very logistically demanding, especially in the 2x2 factorial designs, because you have to power for different conditions. So moving forward, we likely need a combination of these approaches, so active placebos, alternative trial designs, and we also could consider potentially moving towards like managing and measuring expectancy. So much of the field is moving toward having independent blinded raters and also using these expectancy management scripts. So in your informed consent process, you're kind of shaping the expectation rather than eliminating it entirely. The second piece is that we do have measures for expectancy and blinding that we should be using more broadly. So we have the CEQ, the SETS, Bangs Index, and critically, we don't want to just be measuring these in participants. We want to also be measuring them in therapists and raters because their beliefs about treatment allocation can influence both behavior of the participant, their own behavior, and also the outcome assessment. So the broader point here is that if expectancy and blending are part of the system, and they almost certainly are, then we need to be treating them as variables in our models, not just limitations that we acknowledge in a discussion section. And so far, I've kind of focused on these issues from a methodological perspective, but they also have very real regulatory implications. So, a recent example being the MDMA assisted therapy for PTSD issues with the FDA, where they ultimately decided they were not going to approve this because of the issues of blinding and expectancy. So, we need to be aware that even promising treatments may struggle to meet these regulatory or evidentiary standards required for approval if we're not considering these factors. Now, PAP also challenges us to measure things that conventional psychiatric outcome instruments were not designed for. So, how do we measure them rigorously? And as with most things in the psychedelic space, there is debate about whether the psychedelic experience is required for the therapeutic response. So, having scales to quantify this are very important. So, measures like the 5D-ASC, the MEQ, the EDI, also the EBI, have all been created to help participants describe their experience and give us some insight into what's happening during like the peak. But these scales have also been shown to predict clinical outcomes in many studies. So, for example, higher mystical experience scores on the MEQ are associated with greater reductions in depression. We also have scales coming out that are more like newer, like the Challenging Experiences questionnaire. There's also a psychological insight questionnaire. And these are trying to help us distinguish constructive difficulty from genuinely destabilizing distress. There's also these newer preparedness and integration skills, which tie into the triphasic model, where they allow us to assess factors like mindset and emotional readiness going into the session, as well as how individuals process and incorporate their experience into their daily lives afterwards. So, tying back to things like set and setting and trying to understand variability in outcomes across participants. For efficacy, most trials have focused on traditional depression scales, so some of those legacy instruments like the MADRS and the HAM-D. These are obviously useful and well validated, but they were designed for gradual symptom change, not the rapid experience-driven shifts that we see with psychedelics. So while they may be capturing part of the effect, we also need to start considering supplementing them, potentially with something like the MARS, which is a rapid-acting antidepressant scale. We also should be considering patient-reported outcome measures as essential in our studies because the treatment is inherently subjective. So we don't want to just be using clinician-rated outcome measures. However, there is obviously the awareness that these subjective measurements are sensitive to expectancy and unblinding. So a kind of triangulation across multiple outcomes is likely the best approach. When it comes to safety monitoring in psychedelic therapy, we often see experiences that look like adverse events. So, anxiety, emotional distress, but they actually may be part of the therapeutic process. So, one of the key challenges is distinguishing therapeutic discomfort from true harm. And tools like the Swiss Psychedelic Side Effects Inventory were developed specifically because traditional AE frameworks don't capture these psychedelic specific effects like existential distress, for example. And they actually allow a rating of severity as well as subjective impact. From a broader perspective, standardization in adverse events reporting is going to be essential as we move forwards because we want to be able to compare findings across trials and kind of build a coherent basis for what we tell our participants are the risks and potential adverse events of these trials. Building on kind of that idea of capturing the full clinical picture, we also want to make sure we're capturing outcomes that actually matter to patients. So I'm not going to cover every single scale on this slide, but the key takeaway here is that psychedelic interventions may affect multiple domains at once, and those domains may not always be moving in parallel. So a patient may care more about, let's say, like sleeping through the night or reconnecting socially with their friends or even like just feeling less avoidant. And maybe they don't care about a modest change on a scale like the MADRS as much as they would as PSQ score going down. So the broader measurement challenge is not just which scale is best, it's also whether trials are powered and designed around the domains that actually matter to our patients. And so we've talked a lot about symptom reduction, which is important, but we also need to know who benefits from these trials, who is at risk, and what baseline characteristics may predict both of those things. And to understand that, we need to be capturing it. So personality disorder assessments can really help us understand how interpersonal functioning may influence things like therapeutic alliance, which, as we have seen, has been linked to response. Skills that capture resilience, trauma history, cognitive flexibility may be used to help us understand why, for some people, a difficult session is extremely destabilizing, but for others, it's therapeutically meaningful. Other constructs that are maybe important are things like absorption, suggestibility, and openness to experience. These have been shown to shape how deeply someone responds or engages with a psychedelic state, and that could help predict response. So all in all, this kind of points to a shift away from this one size fits all model where we start proactively accounting for the fact that individual differences in these domains will likely shape treatment response. And identifying and integrating these moderators will be very, very critical for moving towards a more precise and personalized model of psychedelic therapy. Now, I want to close with the broader questions and debates that are shaping where the field is heading. And as Josh mentioned, there are a ton of these, so I can't cover them all, but these are a few that I wanted to mention. One of them being the diversity gap. So, across psychedelic trials, the vast majority of participants are non-Hispanic white. A systematic review of 39 studies found that 85% of participants were non-Hispanic white. And this really matters for a few reasons. One, we know that marginalized communities are disproportionately affected by these disorders, so we need to include them and develop treatments that can help them. Second to that, we know that associations between lifetime psychedelic use and reduced distress or suicidality actually are less consistent in racialized populations, which means that our findings of great efficacy from predominantly white samples may not generalize to marginalized communities or non-white populations. And although this lack of representation doesn't seem to be due to a lack of interest. So there was a Vancouver study out of Canada that found that 43% of marginalized women were interested in psychedelic assisted therapy, but they were kind of hesitant due to structural and historical barriers. So how do we design our trials to take these into account? Well, maybe you start engaging with your community partners directly. You can also reduce practical barriers, so reduce cost of participation and also time. Maybe you offer evening sessions rather than during the workday. Also building culturally competent research teams. So acknowledging kind of the historical context behind these treatments and even like the racially discriminatory enforcement of drug prohibition as an example. Another major generalizability problem is who gets excluded. So many of our current exclusion criteria were designed to minimize risk, rightfully so, but they also limit real-world applicability. So if we take bipolar 2 disorder as a kind of case study, Josh already presented that in most trials, it's been categorically excluded based on the concerns about precipitating mania or hypomania. But emerging data actually don't support this exclusion. So our own group published data, as Josh mentioned, on 4 patients who had no treatment emergent mania and significant antidepressant effects. And Aronson and colleagues as well published a 15 participant open label study with similar results. So although these are small studies, they do suggest potentially that a risk stratified approach rather than categorical exclusion is where the field needs to shift. And the same kind of flavor of concern, if you will, exists for suicidality and personality disorders as well. So maybe we need to begin to think about inclusion based on individual level of risk. So considering things like symptom profile, history, vulnerability, alongside tailoring monitoring and support depending on the risk profile. And so I'll end today by kind of stepping back and highlighting a few open questions that are actively shaping the field. So first, there are still very fundamental questions about mechanism. We still don't know or understand whether the therapeutic effect is primarily driven by the drug and the psychotherapy or either on their own. Related to that are questions about formulation. So are synthetic compounds equivalent to naturally derived ones, for example? And how are concurrent medications like SSRIs influencing response? Second, there are these unresolved methodological challenges. So we discussed the difficulty of finding a convincing placebo, the impact of expectancy and unblinding, and also the limitations to our current outcome measures. So there is kind of this need to develop tools that may actually accurately capture what's going on behind the scenes. Maybe we need to look into digital phenotyping or BDNF markers or DMN connectivity. Another important question is around implementation and ethics. So, what happens after the trial ends? How do we ensure that the durability of the drug continues for 6 months, 1 year? How do we make that happen? How do we design studies that are both inclusive and generalizable while still maintaining safety? So we have made substantial progress, but we're still in a phase where many of the core assumptions are being tested. And so I'll close kind of with 5 core points. So first, the intervention is more than the drug. So we're looking at dose, psychotherapy, set and setting, and also post-trial care. These are all mechanistically entangled with outcomes. Second, many of our core design assumptions remain untested, including dosing frequency, the psychotherapy protocol or the necessity of it, whether a washout period of an antidepressant medication is required, and also our comparator choice. Third, functional unblinding is pervasive. So really, we need formal assessment of expectancy and blinding integrity. And fourth, our outcome measures need to evolve beyond these legacy symptom scales to better capture experience, functioning, and integration. And fifth, equity and access are not just ethical issues, they're scientific issues because who we include and exclude directly determines the validity and generalizability of our evidence. So overall, while Dr. Rosenblat's talk has shown how far the field has come, I hope my talk emphasizes how far we still need to go. And so thank you. I think we may have time for questions and discussion.
Thanks so much, Danica. That was absolutely fantastic. And you have our emails there, so feel free to email us. We do have a few minutes for questions, and it looks like there is some coming through the chat. Any thoughts on differences between synthetic and naturally derived psilocybin? Danica, I know you were just mentioning that. Do you want to share any thoughts you have on that?
Yeah, there's been a few reports that have been put out where subjectively patients have taken both or different options, and they have felt that the natural product is a more grounded experience, more like earthly experience. These are again like narrative reports from patients, not necessarily quantitative results on this, but it's possible. I think it's still just very unknown. Yeah, I don't know, Josh, if you want anything to add.
Yeah, great comments. I think the other part of the discussion is if other components of the mushroom ingredients may be facilitative. So, for example, the interventional product that we use in a lot of our studies is from a company in Canada, Filament, that uses 25 milligrams of naturally sourced psilocybin, but it also has other naturally sourced mushroom ingredients that are proprietary. So we don't know exactly what's in it, but it's this idea where I think they're trying to mimic more so the idea of dried magic mushrooms that have been used for thousands of years in various cultures. So it's a testable hypothesis. We still don't know. It's hard for me to wrap my mind around the idea of if you're comparing pure synthetic psilocybin with pure naturally sourced psilocybin, how these two could be different. So I wonder if it's more so relating to these other non-psilocybin mushroom ingredients that could be helpful or not helpful. So it's a testable hypothesis. Great, great question. What are your experiences with psilocybin and trauma slash PTSD? Danica, do you want to go ahead with that? I'm happy to share
Yeah.
some thoughts as well.
Yeah, there's been a handful of studies that have come out that seem to show that actually the PTSD symptoms improve. I did an analysis as well on our open label trial that found that the participants with PTSD comorbidity actually had improvements in their PTSD symptoms in separately from the depressive symptoms. So it is possible that this is a unique intervention for PTSD, not just like the overlapping symptom domains, but those that are unique and specific to PTSD.
Yeah.
And then, yeah, go ahead, Josh.
Sorry, go ahead.
No, you go
Uh,
ahead. I was,
I was going to say, if you're interested in more of this topic, Charles Choi from our group wrote a nice systematic review published in Journal of Psychopharmacology last year that systematically reviews this. And there was one report from Scott Aronson with psilocybin in suicidal depression where he found PTSD comorbid to be a negative predictor of response. So still a question, but I think the sample size was pretty small. So there is some promising data that it might help with PTSD symptoms. And as Danica mentioned, our unpublished data on this as well is suggesting benefits. Is the psychotherapy part of PAP unique to guiding a patient through an optimal psychedelic experience? And what is the appropriate comparison therapy by which to judge improved efficacy by combining with drug? Yeah, so there has been some uniqueness to the psychotherapy where it typically is a custom design. There has been some people that have proposed this idea of just, combining with pure cognitive behavioral therapy, but the studies that have been done by our group and most other groups have been using protocols. For example, the Yale manual is being used by a lot of groups, including ours, where it is a specific protocol that was designed for psilocybin-assisted psychotherapy. And the Yale manual, for example, uses ACT, but there's so much in there that's just more so non-specific to ACT, but more so specific to psilocybin in terms of preparation and psychoeducation for the experience, returning to intentions, all of those things. So it does seem to be a specific protocol in most studies. Um, what do you think of the new meta-analysis by Williams and JAMA Psychiatry, finding that there's no difference in efficacy of psychedelics for depression versus standard antidepressants given open label? Fantastic question. I wish that I had more time to answer this because we have a lot of thoughts, and there is some pending publications in response to this as well. Essentially, I think it is fundamentally problematic to compare RCTs with single arm open label studies. The difference between an RCT and a single arm study is much more than blinding, as evidenced by there are open label RCTs as well that have reduced efficacy even when it's fully open label. So the idea of saying that single arm studies are completely comparable to double blinded RCTs, even if there is high degrees of functional blinding, is something that I fundamentally disagree with. So very interesting analysis, but I think you're comparing apples and zucchinis here. So I don't think that really decreases my enthusiasm for studying this further. Danica, I don't know if you had any other thoughts on that one.
no, that was a great summary.
From a pharmacological viewpoint, how do you reconcile the issues that 5-HT2A agonists and also 5-HT2A antagonists, antipsychotics, both have antidepressant effects? Yeah, great question. I'm happy to share some thoughts. Danica, any thoughts on that, or do you want me to take this one?
Yeah, you go ahead.
Yeah, so I think one of the key points is that there are so many other targets for both psilocybin psychedelics as well as for antipsychotics. I love the Stephen Stahl images that show just the large number of receptors that are targeted by antipsychotic medications. So 5-HT2A antagonist effects are one part of it, but there are many other parts. So that's one part to recognize both for psilocybin and for antipsychotics. But then the other thing to think about is how are these actually quite similar from the perspective of antagonism and desensitization through potent agonist effects lead ultimately to a similar effect. So when you look at things like mirtazapine, trazodone, and second generation antipsychotics, they're all leading to decreased signaling through 5-HT2A. So even though psilocybin and related psychedelics acutely increase 5-HT2A signaling, this does potentially lead to desensitization, so decreased 5-HT2A signaling in the medium to long term as well. So there is that similarity also. So great question, but I think it doesn't really explain the whole story basically. How do you manage reporting, documenting adverse events that may be assessed as potentially therapeutic, such as anxiety? Great one, I think, for Danica. Do you want to tackle that one?
Yeah,
Managing
yeah.
reporting of adverse events?
Yeah, I think that's kind of what I was getting at in that one slide there. And I think previously we didn't really have the tools to say that this was a therapeutic effect. And so you could only report it as an adverse event. But these new skills, like the Swiss Psychedelic Inventory, gives patients the opportunity to respond to whether they think it was kind of like therapeutically meaningful to them. And I think also you can narratively gather that from your therapist notes as well, depending on how you're doing your integration. But whether or not you want to quantify it as like fully negative, neutral, or maybe a positive experience, may be more qualitative in nature rather than just quantitative of saying this adverse event happens at this frequency.
Great. And then we have one a question about a placebo alternative, myristicin. I'm not familiar with this molecule. Danica, did you come across it in your reading?
Not in my reading. I looked it up quickly. It just looks like it's an organic compound that has some potentially psychoactive effects at high doses. So I'd have to look into it more, but I think that is kind of what the field is progressing to, is trying to find other things that do not have therapeutic effect, that have some kind of psychoactive effect that we can use to blind our treatment conditions. So maybe that's an interesting possibility for future studies.
Zoran, I'm not sure if I'm saying your name correctly. I'm not sure if you're able to unmute. If you want to share something on this, just because neither Danica or I have heard about it, feel free to unmute yourself and share if you have any thoughts about it, if there is a study or something.
Okay, hello.
Hi there.
Hi there. Zoran Dermanovic, I'm the chief of psychiatry in Klagenfurt in Austria. And myristicin is a psychoactive compound of nutmeg and is forensically known as a compound oftenly abused in the prisons. The specific hallucinations are those of size, either by being great or small. There is a certain level of toxicity in high doses, but even in lower doses or mid doses, it produces a considerable psychoactive effect. Uh, its toxicity is only pronounced in prolonged use, but for a single use, it could convince the participants of the study that they are receiving a psychedelic, but without any receptor activity that is actually researched. So it could be a good possibility of a placebo.
Thanks so much, Dr. Domenovich. That's fascinating. We'll have to definitely read into it more. Thanks for the suggestion. I see we're just past the 10 o'clock, so if there are further questions, please feel free to email Danica and I. It's been a pleasure joining all of you around the world. Thanks so much for your attention, and looking forward to having further sessions, hopefully to cover, some of the preclinical work and other
Thank
areas
you.
from the GNC. Okay, thanks so much, everyone. Have a good day.
Thank
Thank
you.
you.